Okay. Hi, everyone. We're Group 1 from Allergic Rhinitis. And today we're going to talk about over-the-counter medications for allergic rhinitis. I'm going to start with the main symptoms of allergic rhinitis. The main symptoms of allergic rhinitis include sneezing, nasal discharge, congestion, and itching of the nose, throat, and eyes. Many patients also experience postnasal drip, coughing, and fatigue. It is also often associated with asthma and can occur year-round, seasonally, or after exposure to specific allergens. Seasonal allergic rhinitis, commonly known as hay fever, is about 10 times more common than perennial forms, with ragweed pollen being the most frequent cause. Before we get to the medications, there are two main non-drug therapies that are recommended for everyone. First is avoiding allergens. Patients should limit exposure to known triggers such as pets, dust mites, pollen, and mold. Practical steps include using air conditioning instead of opening windows to reduce pollen, keeping indoor humidity between 30 and 40% with a dehumidifier, and using protective mattress covers. Washing bedding weekly in hot water and removing carpets can also help. Second is using nasal saline. Saline sprays or rinses can relieve mild symptoms by flushing allergens from the nasal passages and soothing the nasal lining. They may be used as needed, once daily for maintenance or twice daily during symptom flares. It's important to prepare saline with distilled, sterile, or previously boiled water since plain tap water isn't sterile.
All right, so now we're just going to talk about the over-the-counter pharmacology that's available for this allergic rhinitis. So there's four main medication class that includes antihistamines, nasal decongestants, intranasal, and then intranasal cromolyn. And then across that, all four of the classes, there is 24 total generic medication that's available. So the antihistamines includes like your lortidine, your diphenhydramine, and that comes in oral tablets, chewable tablets, your liquid filled capsules, syrups, and then some are also found in nasal spray. Your intranasal corticosteroids, those come in nasal sprays, and then your decongestant, so your oral, so that's your pseudoephedrine, and your phenylephrine, those comes in oral tablets in either immediate or extended release. And then your nasal, your oxymethazone, your phenylephrine, or your xylomethazine, those come in like nasal sprays. And then your mast cell stabilizer, which is your intranasal cormolyn, that comes in a nasal spray.
Okay, so we're going to go into each drug class a little further. So antihistamines, the mechanism of action is they competitively block H1 receptors on peripheral smooth muscle. So this decreases histamine activity. This is effective for patients for improving their sneezing, itching, runny nose, and eye symptoms, but it's less effective for nasal congestion. And there's three categories that we're going to go through: the first generation, non-sedating or second generation antihistamines, and then intranasal. The first generation antihistamines, this is like your Benadryl, so diphenhydramine. Onset is 15 to 30 minutes, and they reach a steady state quickly. The dosing's pretty frequent, so every 4 to 6 hours for Benadryl. One thing with this medication is if it's used for weeks to months, it can induce hepatic enzymes to increase its own metabolism, so people can develop tolerance. The most important thing, though, is adverse effects. So first generation antihistamines are sedating and they have anticholinergic effects. So they're contraindicated for our elderly patients. It's on the Beers list, for lactating women, anyone with BPH or glaucoma. For those patients, they can take non-sedating antihistamines. So these are like your cetirizine. I have them listed over on the left side there. So Zyrtec, Claritin, and Allegra, those are the brand names that you might be familiar with. These also have a rapid onset, and they're better tolerated than the first generation medication. So less cholinergic effects. They're okay for our elderly, for glaucoma patients, BPH, still contraindicated in lactating mothers. And then you can see for fexofenadine there on the left side at the bottom, there are some drug-drug interactions to be aware of. They're they have interactions with inducers, and then there's also some absorption issues with some foods that are listed there, and they should be avoided with QT prolonging drugs. For intranasal antihistamines, this is azolastine and olopatadine. So these are effective for sneezing, rhinorrhea, nasal pruritus. They're generally pretty well tolerated and just contraindicated for known hypersensitivities. For nasal decongestants, the next category, these are alpha-adrenergic agonists, so sympathomimetic amines related to norepinephrine. These decrease nasal congestion by vasoconstricting the vessels in your nasal mucosa. So they come in oral or topical formulations, so nasal sprays or oral. And then you have to think about central nervous system stimulation with these medications. For oral nasal decongestants, this is stuff like Sudafed, phenylephrine or pseudoephedrine. They also come in a lot of combination medication. So you'll see them combined with antihistamines, pain relief, caffeine, in things like cold and flu marketed medications. They have a quick onset, but the problem here is the nasal decongestant wears off in 4 to 6 hours, which is before the next dose is due. And then they have a lot of adverse effects. So since you think about norepinephrine, they increase blood pressure, increase heart rate, CNS stimulation, so insomnia, irritability, restlessness, and these are contraindicated in a bunch of patients. So people with hypertension, seizures, pregnant women, not for children under 12, anyone with heart disease. And then if a patient is taking an MAOI or has taken one within 14 days, they should not be taking this medication. For topical nasal decongestants, this is your Afrin, so oxymetazoline. These provide rapid, dramatic improvement in nasal congestion, so patients tend to really like it. The problem here is they also cause severe rebound congestion if they're used chronically, more than 4 days, or overused. So if this occurs with patients, they need to stop this medication and then replace it with either an oral nasal decongestant or isotonic nasal spray or both. And children under 12 can take this medicine. There's just some age-related dosing considerations. Intranasal corticosteroids, these are the most effective therapy for allergic rhinitis. We have the examples listed there. So these reduce mast cell granulation. They disable antigen-presenting cells, which reduces mast cell granulation, so decreases histamine and cytokine release. What this results in is a weak inflammatory response from the patient, so they have mild or no symptoms of runny nose, sneezing, nasal congestion, and itching, and they're generally very well tolerated. Very little adverse effects. There's some question of growth suppression in kids, but this really hasn't been substantiated, and no drug-drug interactions to worry about. And then the main thing here too is they have a slower onset, and then they reach max effect in 1 to 2 weeks. This is important for seasonal allergic rhinitis because you need to educate patients to start this medication 2 to 4 weeks before allergy season. Pregnant women can take intranasal corticosteroids. The recommendation is for mometasone or fluticasone because they have the lowest systemic absorption. And then finally, intranasal cromolyn. So this is a mast cell stabilizer, decreases histamine and cytokine release. This can be indicated for prophylaxis. It's over the counter, but generally considered a third-line treatment. And this is not to be used for acute treatment.
All right, now I'm just going to go over the medication safety issues. So as Shauna mentioned with the common safety issues, so especially with diphenhydramine in older adults, it causes like the anticholinergic effects along with the increased sedation effects. And then with the prolonged use of the oxymetazoline, it can cause rebound nasal congestion. But the biggest thing is the medication, the prevention methods, so patient education. So adherence is very important. So they actually need to follow the like clear labels, like actually follow the directions and avoid triggers. So like the dust, the pollen, pet dander, pharmacist education. Some of these medication has pretty severe drug-drug interactions, so they can't take certain medications. Again, like clear label warnings and reading, so like following the instructions, and then medication reconciliation. So just be mindful of like the certain medications that you're taking with the drug-drug interactions, and then keep up with like your follow-up appointments because you might need to assess if certain medications are working for you or not.
All right. I will briefly summarize our OTC cost analysis. We combined on-site check with an in-house review of FDA labels and clinical guidelines. Our team visited CVS, Walgreens, and Target in New York, Washington, Maryland, and Hawaii, and verified retail prices for brand versus generic and photographed the pack size. For each product, we calculated the unit price, 14 and 28-day cost, per pack cost, and total treatment cost, reflecting real-world pack-based purchasing and exposure duration. These are the picture. All right, as you can see the table, we selected the typical brand drug per class only. So you can find the average cost, including treatment cost and the total pack cost, as well as recommendation on the right side. When we looked at the oral antihistamine, the first generation agent, which are recommended only for short-term use, came in smaller packs, and the price difference between the brand and the generic was minimal. In contrast, for the second generation antihistamines, over a 4-week period, the brand generic gap often exceeded $30. So, for long-term control, we recommend steering patients toward the larger packs and generics, and consider adding an intranasal corticosteroid based on their symptom profile. For intranasal antihistamine, our 4-week comparison showed roughly a $15 price difference in many cases. If symptom control is adequate, depending on insurance coverage, it may be reasonable to switch to prescription options. For intranasal corticosteroid, we use the fluticasone as a reference because it's widely known and available in multiple generics, which makes chronic use much more cost-effective. Since these are the maintenance therapies, it's important to plan regular follow-ups to reassess the dose, technique, and overall control. Intranasal decongestions have slowly short-term low have low short-term costs, but should be used briefly to avoid rebound congestion. Cromolyn has limited generic availability. Most patients should try first and second-line option before cromolyn, unless specifically indicated. Turning to guidelines, as summarized in JACI, management differs for seasonal versus persistent allergic rhinitis and is stratified by severity. We typically step up to prescription therapy when OTC therapy fails, specific symptoms dominate, or comorbid conditions are present. Examples include intranasal corticosteroids and intranasal antihistamines and INCS plus INAH combination for refractory cases. If rhinorrhea persists, ipratropium nasal may be added. Montelukast is in first line, but can help select patient. And for severe IgE-mediated cases, allergen immunotherapy may be considered. So take-home summary. Overall peak size and duration drive real-world cost. For short course, brand generic differences can be small. For long courses, the generic and larger packs have been substantial, and INCS, INAH combination can improve control. When OTC fails, escalate to guideline-based prescription options. Thank you for listening.